And you can keep saying your question. So what was your question?
If someone is BRCA1 or BRCA2, can we do prophylactic mastectomy?
Okay, so girls, I've paused the video here because I think the answer to what you guys were asking wasn't very clearly given to you. We couldn't discuss it in rush. So just wanted you to remember that we are just obstetricians and gynecologists, okay? So the answer to this question, whether they should have a mastectomy or not, is not really for us to decide, okay? I don't think that patient or examiner, I mean role player or examiner is going to ask you this question, but just to be mentally prepared for it in case somebody asks, you need to remember one thing, that you can just say that this does fall outside my level of expertise as an obstetrician and gynecologist, but I can definitely, what we do is there is this because of the BRCA1 and BRCA2 genes, we know that you are at high risk, and the mastectomy is not the only option that's available.
There are other options like, there's chemo prevention. You can say it in patient language. I'm just answering you so that you remember that if the examiner asks you or if the role player asks you, then you can mention these things, that there are other ways, like we can sometimes do just regular surveillance, or can do chemo prevention, or can do prophylactic mastectomy, or stripping, or oophorectomy, or both, okay? So there are various options, and tell them that what we can do is we can refer to the breast cancer MDT, and they can decide on what to do, either a breast cancer surgeon or a breast cancer MDT. We can probably refer to a breast cancer surgeon and they can add to the breast cancer MDT. Okay, so because this is not like 2-week pathway, this is just those people get referred quickly to the MDTs. This is the matter of having like the BRCA1 and BRCA2 genes, and we want to send them to the right people. So we can say that we can refer you to the breast cancer surgeons, or and then they can discuss in the MDTs, okay, and they can suggest whatever appropriate management is available to you. So I hope this should cover your, basically whatever you need to say there. This should be enough for you to say. That's it really. You just need to know what are your options, like if you as an obstetrician and gynecologist, what options are available, right? And I mean, where you can offer her risk-reducing BSO, as she completed a family, and things like that.
Okay, thank you.
Okay, but the important aspect here is that BRCA gene carriers, we can give them HRT after the risk-reducing BSO. Okay,
BSO. Yes.
That's for sure. That's the latest. Okay. Okay. Any other question, girls? Mastectomy. Search that. Any other question, girls? You all are well prepared. Looks like no other question.
Can we be asked about forest plotting, please?
For forest, yes, why not? They can do in the teaching one. I did make a small video, like I think a 10-minute video on the forest plot. Just go through that. It's very easy.
Okay, I haven't seen
it's in the YouTube videos.
Okay.
It will be not in the OSCE ones. It will be probably in the part 2 ones, because the part 2 student I've made a video for the part 2 students. So please go through that. It's very easy. Just watch it. It's a 10-minute video. Okay. And yes, they can ask. Yeah. Anything else? Neonatal resuscitation, you should hear some audio for that as well. That should be good, because they can. So ask me obs and gynae questions, please. The OSCE, the real obs and gynae stuff. Okay. So anything else that you want to know? Anything else, girls? let me,
36 weeks pregnant with HPV, low-lying placenta. The day 1 question.
that was a Wart, not really HPV positive thing or something. That was just a Wart, the Papilloma Wart, proper Wart, yeah? Was
Maybe.
it?
It was written like HPV, warts, query.
Yeah,
and-
yeah, Wart. Wart and
It was,
rubella.
what I've heard that it was a Wart. What's the implication of the Wart being there? If she's symptomatic and very, very troubled by the Wart, only then she will require treatment. Otherwise, no treatment is required in the pregnancy, okay? If the Wart is too big and it's obstructing the birth canal, then you will need to see what needs to be done. Consultant's input may need a C-section rather than a vaginal birth, okay? And that's preferred on treating the Wart really, okay? Sometimes the Wart removal may be required. What are the implications? So suppose it's not obstructing the birth canal, it's just sitting outside there, you know, somewhere in that zone, and she wants to know whether this, what happens to the baby. So it doesn't really get, most of the cases don't get transmitted to the babies, but in very rare cases, it can cause the laryngeal, you know, those laryngeal warts in the baby, okay, in the mouth or the larynx of the baby during the process of the birth, okay? That's the implication. If she is not wanting to take risk, even if, you know, even given that it would be just rare, then she can still be offered a C-section, okay? Normally we'll reassure that, look, most of the times it that won't affect, okay, we may be able to, there's may is your rescue word, you may be able to offer you a C-section, but and I'll need to get some input from my consultant. If he's happy, we can offer you a C-section. But these are the pros and cons, and you will need to tell her the pros and cons of that and that. Okay.
Ma'am,
So
if
you have
patient
to-
want to go for treatment of this wart and this time for cesarean section, so should I say that after your delivery we can arrange a treatment
If
of
she
your
wants
wart
treatment
removal?
right now, then we don't say after delivery. If she says treat it now, then we say, okay, these are the options. Cryo is available, surgery is available, laser is available, okay? And you say that I will refer you to the appropriate clinic who can do that, okay? We don't do that, I don't do that. Obstetricians and gynecologists, I've not seen them. Maybe vulval clinic people will be doing that, okay? Or gum clinic will be doing that. So you can say that I'll find out whether, you know, vulval or gum clinic will be able to do that, and I can definitely refer you to them if this is something that you want to consider right now. Okay.
And today's task is
Okay.
3 years old, and she
How
has
How many?
40 years or 44 years old, and history of
Okay.
recurrent miscarriages, 3 miscarriages. Then we will be offered for the EPLA and other things to be tested. Like in the 40s, already
You tell me. You tell me.
40 years old, she's already, you know, the range of miscarriages of like age. Why we would offer the EPLA and everything like that?
So why would you not offer? You are thinking that 40 years not the age when she can qualify for IVF and things like that. Okay. But if she's conceiving naturally and she's miscarrying, then why not? What's the 40-year? What has the 40-year got to do with the APLA? Okay, so she can still have, maybe she was a busy person, she started trying to conceive late and she ended up with this. Maybe she suffers from, you know, antiphospholipid or some other thrombo defects. So definitely don't worry about that, oh, because she will be an elderly mother or something like that. You are not going to decide when she conceives or when she doesn't. She plans to become pregnant, she plans to become, it's her job, it's her decision, it's her choice. So yes, she wants to get pregnant, she's having these consecutive miscarriages, her age should not stop you from, you know, to discriminate. The only thing that can, you know, be important is if she was to you know, request IVF, then you will need to see, okay, between 40 and 43 you can get one cycle and all that. That's a different story. You don't bring that age into other sections thinking that that's related to her pregnancy, so let me apply that here as well. So you don't need to do that. Okay.
When not
Clear?
time to perform the online exam, not time.
Is that not time in online exam? Well, the interesting thing, let me tell you, is that somebody was having their online exam and they said that no, not online, they had their face-to-face exam and the neonatal resuscitation came. And the interesting thing that they told was that this candidate didn't have to touch anything. The person who was learning, your junior who wants to learn, he was doing everything, which means the same can apply to the online as well. So I don't know what can, just be ready with a little bit, just 1 or 2 minutes, spend 1 or 2 minutes, not more. You can't really tell without the specimen. Maybe you can tell about neonatal resuscitation. I don't think you can explain a knot tying on, like, how will you do it? You don't have anything in front of you. So if I was sitting there, I would not prepare for knot tying and I didn't prepare for my online exam. I didn't go through the knot tying and all that. Okay.
It
You
was
have
a
to
bullying
receive
station, I
things.
guess. Not time was a bullying station.
Knot tying was a bullying station. I didn't know
Yes.
that. Okay.
Yes.
Just explore. Okay. Yeah. Just explore, and then the focus will be more on the bullying.
Yes.
The
Was a
RCOG
bullying
says that
station.
even in the bullying station, you need to know a little bit about the subject as well. Although a person who's crying and who is distressed, you may never come to the actual knot tying. You say, just forget about knot tying. Just forget, just calm down, So you focus more on her, the stress that that your junior is undergoing, whatever the bullying she's having. So deal with that. And I'm hoping, fingers crossed, it's never going to go to the stage that she says, okay, now tell me how to tie this knot. So I hope that it doesn't go to that stage. Did the candidates tell you that it went to that stage that they had to then teach as well? Yeah, I've just seen your sticker. So did somebody say that they had to teach as well, despite all that?
No idea.
No idea? Okay. So no worries. So if it's coming as a bullying station, just remember that the more focus will be here. RCOG says, and I'm telling you from the RCOG what they said in our course one minute. And RCOG said that in the bullying station, if you don't know the subject matter, um, knowing would be probably better, but if you don't know, then reassuring the other person that, okay, even I don't know that thing, but that was not about knot tying, because obstetricians should be knowing how to tie the knot. It was about odds ratio in that case in their course. So they said that, you can say that even I don't know, so I'll read and I'll teach you as well, so don't worry. Although they said that if you know a few words to say, a little bit, then that will probably be helpful. Okay. So that's it really. I think the more focus is on, but do you know how to handle the bullying and all that?
So we can say to her then in next meeting when we will meet, I will show you how to tie a knot. Because
I think if
we
you
cannot.
know that is coming in the, so listen, Atya, I think if you now know that this is coming in the exam, then read 2 words about it so that you don't have to say. But why I said all this, why I gave all this lecture was, the reason was that if something else comes and you are, startled that, oh my God, this is something, how do I deal with that? Then if there's something unexpected comes, then you can use that kind of formula. It's better that you just remember, even if you remember 2 knots, you don't have to remember everything. Okay, just always, just quickly, if you can, 1, 2, I can say this, and then, okay, so we'll, you're too stressed, we'll cover this later on. There are more knots as well, we'll do that later. So just, get rid of it.
Okay.
Right?
Okay.
So now that you know that this station has come, so there's no harm in going through 1 or 2. Okay. But don't need to master everything, because we don't know whether they'll give it on the online exam. Okay. I don't see how can they give in the online exam. I mean, but I've heard weird stories about this exam. So I've heard weird stories about this exam. Now, I've heard that the role players were laughing.
This was not online exam. Tomorrow.
I've heard that the face-to-face exam in India, the Breaking Bad News cancer role player was laughing and non-serious and all that. So I was quite shocked to hear that. So so much so that the poor candidate, she said that I thought that she's gone mad with her sad news. Can you imagine that she's thought that this is a part of the role play, that she's laughing? She's gone mad with the bereavement. Not bereavement, but
Yeah.
Yeah.
Now
Hmm?
Ma'am,
Sorry.
sometimes role play doing exaggerated role play.
Sorry.
Sometimes role player are doing exaggerated, more, what should I say, more acting. So
Exaggerated.
that sometimes
ex-
make us laughing, I think.
No, it was
Oh,
not. It was not exaggerated. It was not exaggerated. It was the role player themselves laughing. Oh, jump on to the next question.
Ma'am, 144 years female, SD discussion with multiple fibroid and FSH was raised. And what will be the fertility option for that?
So you tell me first, Poonam, what's the fertility option for her?
Ma'am, she is in age of 44 and FSH is rising. It means she is towards menopause, perimenopausal age is there. So surrogacy cannot be offered because ovaries are not working. So adoption.
Ovum donation?
Ovum donation, egg donation and surrogacy, ma'am.
Surrogacy,
egg donation.
how can we stimulate the eggs for surrogacy? She's towards
Partners sperm and egg, donor egg.
Okay.
It can be, look, she has a fibroid uterus. Fibroid uterus doesn't mean that her uterus will not conceive. Okay. So it can be either in her fibroid uterus, that's fine. Fibroid uterus become pregnant as well. But if the fibroid uterus is deemed as, being the hindrance in her, just say, you are not the expert. You have to remember there is a fertility MDT as well, but you will be giving potential options. You will say that the potential options for this lady are, first of all, determining her ovarian reserve. I will want to say, looking at her high FSH, I want to do an AMH or some method to assess her ovarian reserve. She may be at the end of her reproductive years, which means that I can probably offer either she'll probably require ovum donation that can go into her womb, like her uterus is SDs in it. So this can either be implanted in her own uterus or as an ovum donation, or she can have ovum donation and a surrogate mother. So surrogate can be stimulated and she can be the biological mother as well, or there can be another biological mother. Okay, so ovum from one surrogate, the other person can be a surrogate and all that. So that can happen, why not?
Ma'am, she has multiple fibroids last. So any
Multiple
role of
fibroid and 44 years,
Okay.
ma'am. There is some
myomectomy,
Yes.
should we say, ma'am?
So the myomectomy does not increase the live birth rate. Just remember, okay? Even the what's that called? Intracavitary fibroids, even removing them hasn't been shown to increase the live birth rates. Okay, so I shared something in the group some time ago, I think a few months ago, where it said that if the fibroids are subserosal, they don't affect. If they are intramural, then the evidence says that they don't affect the live birth rate at all. Only the Canadian guidelines would say that the removing the subendometrial fibroids may be helpful, but the UK guidelines don't promote even the removal of the subendometrial fibroids. So what's left? So as far as the fibroid is concerned, this is the consensus. If the patient or the consultant or the MDT can still decide that, okay, let's try removing her fibroids. This patient probably, yes, FSH high, fibroids, and what else was there? 44-year age, yes. So we are going to say that I will explain to this patient that removing the fibroids may not increase the live birth rate. Her FSH is high. I need to check the ovarian reserve and see all this. And because she has not conceived naturally, she does not qualify for IVF anyway under NHS. So is she able to afford privately? If she can afford privately, then even private clinics may not all the private clinics may be accepting a woman over, 44 years of age, but that still is possible. It's not impossible. So giving her these options, if she still wants to go ahead with the pregnancy, I will need to inform her all the conditions that can, obstetric and the medical conditions that can affect her, this like a VAMA, very old maternal age, that I will give her the details that her pregnancy will be affected by so many things, and can be potentially affected by so many things, and these things. So then in the after scaring her with everything else, what's left? So if she still wants to go ahead with an IVF, and she can pay for it, then these are the chances. Removal of the fibroid is controversial, but if I will let the gynae. Please remember the sentence, I will let the gynae fertility MDT to decide whether to remove this fibroids or not. Okay. This is a controversial topic because evidence does not support the removal of these fibroids. When you said that this is what they want to hear from you, they don't want to hear from you that, I'll do this, because they have put it there because this is a complicated. They want to see how you talk about this. Are you able to talk like an evolving consultant, or you're not able to do that? They're not wanting a decision from you. Will you remove the fibroids? Will you do this? Will you do this? They're not wanting that. They want to see, you are an ST5, are you an evolving consultant, or you are not? Okay. So is this clear, or anything still unclear here? So they don't need perfect answers from you. Options will include, say, these are outside this complicated scenario. Her other options could be surrogacy using partners' sperms and some other mother, and with ovum donation, surrogacy with ovum donation, adoption, fostering, and everything. Okay. And then if you were a very good, excellent candidate, then you will say, before she goes, I'll also want to inquire whether these massive fibroids have been causing any severe menorrhagia in her or any pain, although the removal may not help with her getting pregnant, but does she require the removal of these fibroids for gynecological symptoms or not? And if she does, then, I'll offer her accordingly. Get my point? But that's
Yes.
something very, very, like, if you are really good and if you can handle all the obstetrics and fertility related issues in time, and then you can, and you will look so clever, like, the examiner will say, oh, she even said that. Okay. Right? That if, telling what the medical complications can be with the pregnancy at this stage, if the woman then decides that she doesn't want pregnancy now, then I will want to make sure before she goes that whether these fibroids are causing any gynecological symptoms enough to warrant to require any treatment. Okay. Right, girls. Next.
Ma'am, a person with sperm count 6 millions, and he has got a diabetes, HbA1c, some 14 like that, ma'am.
Okay.
Has come for what are the options for him, ma'am?
You tell me, Manika.
Yes, ma'am. First, we have to treat his diabetes. If he has got any, this anyway, it is important for his health. There may be some ejaculation or erection problems or low libido like that. So here that has to be handled first. Then we should verify whether we should investigate whether he's taking some steroids or like that. Then he'll be referred to the.
So first of all is that you may not see that, we say that multiple diagnoses are usually not the case. So usually if he is a diabetic, then he may not be a case, but you will rule out, yes, that, just in case that he's taking any steroids or not. Yeah. So that's fine. Don't expect that he'll be taking, but it's good to rule out. But your focus is that, okay, so one good thing is at least we've reached the bottom of this, that we know that this is happening because of diabetes. controlling the diabetes is not only important for your fertility issues, it's very, very crucial for your general health as well. So I would really recommend that you control your diabetes under the care of a multidisciplinary team. We'll refer you to, are you already under care of a diabetologist? So find out how do you monitor? Is he already a diagnosed person? Then how does he monitor? What is usually the range of the hemoglobin A1C that he is in? And he can say that I've been trying for last 4 years and I'm not able to control my sugars. If that's the case, then they will probably be able to do the ICSI on him. Okay, if he hasn't been able to anything, then they will alongside referring him for diabetic care and all that, alongside that, they may be able to offer him ICSI because his partner may be running out of, her reproductive years. Okay.
Yes,
so that's an option. So keep your mind open and spread out. We'll deal with this, we'll deal with this, we'll deal with this. Okay. Your control of your diabetes is extremely important. Young patient, you can say, yeah, let's stabilize you, and then you can go for a natural one. That's one option. Or we can also, refer, if he says they've been trying for 2 years, then of course there's a point in referring to, say, fertility MDT, and they may be able to offer an ICSI to him, but then ask him any existing children or the partner has any existing, you always should think in all directions, whether it's he's suitable for funding, and he may not be suitable for funding, but he may say that I can afford privately. So ask all the questions. That's why I keep on saying bubbles. Okay. Then your thoughts bubble when you make bubbles. Okay. So yes, you will think in all the directions. Don't miss any such aspect. Okay. Yes. Yeah, Manika.
Ma'am, is there any possibility of you using this retrograde ejaculation? There is the sperms from the urine, some alkalinization
No,
of
I've
urine.
never.
No,
They don't do that.
Okay.
No, they don't do that. Okay. So they will directly get it from there.
Yes. Okay.
That would make it too easy for them. Okay, you retrograde, ejaculate, and we'll just get it from the urine. So no, I've never heard of that, and no. Okay, right. So, anything else, girls? Okay.